Good evening and welcome. Tonight's program got DX. My name is Bob Salehi. I manage scientific and clinical communications at BIOTRONIK, and I have the distinct pleasure of introducing our guest speaker tonight, who needs no introduction, by the way. Dr. Luigi Di Biase is the System Director of Electrophysiology at Montefiore Health Systems in New York. He's also the section head of EP at Einstein Montefiore Health System, as well as professor of medicine at Albert Einstein College of Medicine. Dr. Di Biase is a world-renowned electrophysiologist, an investigator, a scientist, widely published in multiple peer-reviewed publications, specific on arrhythmia management, and also the broader topics of electrophysiology, with extensive clinical experience and unrivaled real-world insights on clinical advantages of tonight's topic, BIOTRONIK's DX technology. Dr. Di Biase, welcome and thank you for joining us tonight. It's a pleasure.
Thank you very much, Bobak, and thank you, BIOTRONIK, for inviting me tonight, and thank you for the people that will spend some time listening to me. So we're gonna, talk about DX, and before we do it, I have to show you my disclosure, which are shown here in this slide. Would like to start saying that, atrial lead in ICD patients without pacing needs as unnecessary complication remain common. This issue affects about 50% of primary prevention patients in the US. DX technology offers dual chamber level of detection without an atrial lead, providing a less invasive, more physiological alternative that also shorten procedural time, both of which contribute to minimizing avoidable complications. This is just an introduction there. But when you compare DX to traditional, dual single or dual chamber ICD, in this slide, you can see that we have a yes, we have yes and yes, we have 1+ or 2+, and implant complication lower, procedural complication lower. Let's try to summarize this slide in a nicer way. And this paper by Dr. Margolis has been instrumental in doing that. So why I like this? I like this because the implant is like just to implant a standard RV lead. This is a typical, apical position, and you will have, a sensing here in the right atrium. There are a few studies. This is a study from Dr. George Thomas showing that the DS is superior to single chamber and comparable with dual chamber in detecting atrial high rate episode. So not really what we call subclinical atrial fibrillation. It's 5.3% with a single chamber, 13% with VDX or dual chamber ICD, with a very high positive predicted value. In the SENSE trial, DX shows superior, subclinical AFib detection rate at 12 months when compared to traditional single chamber ICD, an equivalent rate to dual chamber ICD. In the MATRIX study, we will discuss this later a little bit in more extents, which is the largest DX trial. DX demonstrated a 99.7% detection accuracy rate in identifying this subclinical atrial fibrillation for at least 1 hour. Is the signal stable? Well, we have a stable atrial signal for the long term. In the SENSE trial, you can see that over time, the ability to sense the atrium remain good, just not at implant. And through multiple studies, DS has been proven to provide a longer-term stable atrial sensing, and DX allow correct estimation of AFib burden with reliable classification of AHRE by their duration between 6 minutes, 1 hour, more than 1 hour, more than 24 hours. So new onset AHRE are not rare, while progression is common. In fact, we need to remind, very importantly, and this was shown in the MATRIX study, and I will show you more study later, that The Matrix study presents a compelling example of the need of reliable atrial monitoring. You can see that about 2,000 patients in 119 sites follow for 24 months. 82% of patients with no AF history had new onset AHRE. About 80% of new onset patients had a high CHA2DS2-VASc score. We saw a high stroke risk. About 70% of new onset patients were not on anticoagulation at baseline, and about 31% of new onset patients progressed to a longer AHRE duration and possibly to atrial fibrillation. This is well shown here in the graph here of this nice paper by Professor Hendricks. So, as said, the DX can detect high atrial rate very early. It offers a true atrial signal through the DX lead with a floating atrial dipole. And in the THINGS publication by my friend in Italy, Dr. Biffi, with about 376 patient prospective study, DX was nearly 4 times more likely to detect subclinical AFib when compared to a standard single chamber ICD in patients without a history of arrhythmias at implant. So in the THINK study, the incidence of OSC onset was twice as high in the DX group compared to the traditional single chamber ICD group. The classification and quantification of AHRE burden allow for a wide range of customized intervention, including oral anticoagulation, ablation, cardioversion, and medication. In the REACT DX study, 69% of DX patients with no history of AFib and new onset AA detection had oral anticoagulation initiated within an average of 24 days. So these are extremely important clinical information, also well summarized here in this graph curve. So this where you may say, oh, these are BIOTRONIK study, and the company always look what they want. But look at the literature in this nice paper from European Heart Journal. You can see that when looking at the subclinical AF and the stroke risk, subclinical AF can increase the risk of stroke, and that is not dismal. And when you look at this anticoagulation with edoxaban in patients with a high atrial rate episode, this is the NOAA study done in Germany mainly. 78-year-olds age was the average, high CHA2DS2-VASc, and a duration of 2.8 hours. You can see that the risk of the population was pretty high. The stroke was 0.9% per year versus the placebo was 1.1%. But when we look at the Artesia study, this also very important, similar patient population, AHRE duration 1.4, patients with more than 24 hours were excluded. Again, a high CHA2DS2-VASc with the prevalence of CAD of 37% and PND of 8%. What is the stroke here? 0.78 per year. And, in patient non-anticoagulation with aspirin, 1.24%. And you see the difference between aspirin and apixaban. So when you put together the NOAA AF-NET 6 and the Artesia trial, there is a reduction in all cause of stroke that is less than 32%. There is an increase in major bleeding with oral anticoagulation more than 62%, and an annual rate of ischemic stroke without oral anticoagulation about 1%. And it's important to say that oral anticoagulation shift risk modestly in absolute terms, with the decision that must be, in my mind, individualized, meaning patient by patient. So in this study by Professor Boriani, here published on the European Heart Journal, at 24 months follow-up, 43% of patients with AHRE, 95% patient or over a 10K patient with ischemic stroke, and the stroke rate per year was 0.39. So you can see here the characteristic and the hazard for the stroke event from the age, the diabetes. But when you look at the duration of these events, you can see that the duration it's not really that important when before the 24 hours. So it's important to understand that outside of the chat VASC, for initiating oral anticoagulation, I think the atrial cardiomyopathy concept is very important, because other markers of stroke are the atrial dilatation, the mechanical dysfunction, the P-wave prolongation, the P-wave duration, the P-wave terminal force. And there are some risk factors for atrial cardiomyopathy, like the gender, the male sex, more than 65, hypertension, coronary artery disease, a high ankle intake, and a high BMI for this atrial cardiomyopathy patients. So when you look at this in an individual with more than 2 risk factors, as shown before, increase the stroke rate with a hazard ratio of 3.7. So atrial cardiomyopathy is a risk modifier, not an indication for anticoagulation, or that's the way it should be. So can we use a biomarker to predict sinus rhythm in atrial fibrillation patient? This comes from the East AF-NET 4 with the biomolecule study here. They are trying to predict when, this patient have a risk that is different from the general population. But in conclusion, when looking at the literature, in device detected AF, absolute stroke risk is low. The anticoagulation should not be based on the duration of the subclinical atrial fibrillation. In the Artesia trial, 1/3 means that 33% of patients with subclinical AFib will progress to clinical AFib. So whatever you want to say about when you have AHRE less than 24 hours, I want to anticoagulate, I should ignore it, the risk of bleeding is high. Well, never forget that 33% will progress. So no matter what you are thinking, early detection, and when you progress to clinical AFib, you need to anticoagulate the patient, or you need to do something about that patient at that diagnosis. So the message is, it's important to detect AHRE and to detect this as soon as possible to individualize the treatment that you want. The clinical risk scores remain the dominant driver of therapy, with a chat VASC that outweighs episode duration or burden, and the atrial cardiomyopathy and the biomarker are very useful tool to refine the risk. So what is the clinical impact of 2-lead ICD system? Well, first of all, when you don't have pacing indication, why we're going to put, 2 leads? Despite no pairing need, the majority in this study by Margolis had the dual chamber system. Still in the US, we have at least 55% of patients that get implanted with dual chamber without the need of pacing. And we know from this study, for example, that in-hospital complication rate is significantly higher in dual chamber ICD versus single chamber ICD, 12.8 versus 10.7, and this was statistically significant. And this complication may be from lead dislodgement, from pneumothorax, hemothorax, or any other of complication. So when we're gonna rethink about the atrial lead implantation in ICD patients, more complication, higher mortality, the clinical cost of implanting a lateral lead is not that dismal. So we know dual chamber, greater rate of peripodistal complication and mortality. And I feel if we do not have a real need for pacing, 1 lead is enough. But 1 lead with an atrial sense is probably better and should be the one utilized for what the data say. And as you can see here, in addition of not implanting a dual chamber ICD, what the rate of upgrade, how many times you have to upgrade to dual chamber? You can see that about 98.7% of DX patients did not require atrial lead upgrade. These data are extremely important. Despite the 4.5-year median follow-up of the study by Dr. Mitacchione from Italy, about 1.3% require an additional atrial lead over 4 years is almost 5 years. And the previous study have shown a typical range that went from 0 to 2% in patient developing the need for atrial pacing. So when you say, well, I'll put two lead because I want to improve my sensing discrimination, and it might be necessary that the patient need to pace, well, this is a very rare occasion. The atrial sense can be good also to differentiate arrhythmias. And so the SVT discrimination, it's very important. It's a case. You can see here the VT monitoring zone with morphology that is very similar to the sinus, as shown here in this one. And this is one of our patients, 75-year-old male implanted with an ICD. Settings was VDI with a tachy and VF zone. Patient with no known history of atrial tachycardia AFib, had the diagnosis have a DX ICD implanted for primary prevention. What happened to this very common patient? Well, received home monitoring notification of atrial monitoring events. As you can see here, clearly there's a change in the history of this patient, and events were adjudicated to be atrial flutter with a controlled ventricular response. And the beauty of having an atrial sense, it facilitates the diagnosis. The DX device was able to detect the new onset atrial flutter AFib event as it met atrial criteria for detection. With stable area intervals, the device used the atrial signal for the atrial dipoles, not an AHRE irregularity criteria to determine the arrhythmia onset and termination. The patient was put on appropriate oral anticoagulation therapy without any complication. I have another case for you, which I like a lot. It's one of my patients, 82-year-old woman with the history of NSTEMI, HOCAM, hypertension, mitral valve repair with a maze, left atrial appendage occlusion with a clip, congestive heart failure, and ICD implanted in 2021 with a kind of little decrease EF and a severe asymmetric septal hypertrophy. She was admitted to AD for palpitation associated to generalized weakness, short of breath, and diaphoresis. Again, remember, the patient underwent a maze and NLA occlusion. Medication were amiodarone and aspirin. You can see here the ICD, the clip that she received on the appendage. And in the emergency room, the fellow called me, say, Dr. Di Biase, the patient is experiencing palpitation, but I think she's in sinus rhythm. Maybe I didn't have a good fellow, or maybe I have a good fellow. Is this a sinus rhythm or not? But a few minutes later, fellow called me back. Now the patient is in this rhythm. And what is this rhythm? Is a VT? Is an SVC? Is an SVT? Or what? Well, if you look, I think there will be no doubt that this is a tachycardia, but what about the prior EKG? Well, if I go back, you can see here there's a P wave that we can follow. So this is actually a 2-to-1 tachycardia, but diagnosis can be complicated. But if you have a VDD, you can just interrogate the device, and that was done. The patient received adenosine, terminated the tachycardia, and revealed an AT. Clearly, you see the atrial lead showing the conduction and making the diagnosis. So a complicated case became a very simple case because the patient had an ICD with an atrial sense, and that was very important. This is actually the real sinus rhythm. So the PR was not long. The short PR is sinus. The long PR is tachycardia. And now we know it. And every time the patient in telemetry has a short PR, we know it's sinus. When it's a long PR, it's not sinus. Although it may look a sinus with in a first degree heavy block, but that's the beauty of the case. So the patient came to the lab. We did an atrial map here, which didn't reveal any early activation. So we went in the left, and the maze was well done. You can see almost everything was red, but there was an early activation here in the anterior wall, here almost at the base of the appendage. We went in that area. We burn in this area, and by burning that area, we terminated the tachycardia. We extended to the area of scar anteriorly, the lesion set, and after, I would say, now is 18 months follow up, no recurrence, improvement of symptoms, EF improved from a low EF, and I have to say that we were able to discontinue amiodarone after this ablation to this patient. So very useful tool to have the VDX here. And this is the follow-up at, I said, now it's actually almost 18 months. So let's go back to what we were saying before. When you have true atrial sensing versus surrogate for atrial tachyarrhythmias, like the emblem, you can have, a true AGM is always important. Now, we've been comparing with the single chamber ICD with the dual chamber ICD. How about, SICD, which only relies on QRS morphology, RR internal variability, or EVICD, with which have, no atrial sensing. So AF and AHRE detection are clinically actionable events. Many clinicians would not consider detection as optional. And I think these are very important points that we need to consider in this topic. And when you look at inappropriate shocks, so we have been seeing strokes, we have been seeing diagnosis and discrimination of supraventricular versus ventricular arrhythmias. How about inappropriate shocks? You can see here that there are always a lot of difference between the detection of inappropriate shocks, and I think then when we look at the patient selection for non-transvenous ICD, patient with a high infection risk or no venous access, patient who do not need any pacing now or likely in the future, and patient with complex congenital anatomy. The patient selection for dual chamber ICD, a patient who require atrial pacing, and the post-operative congenital heart disease patients. But what the patient selection for the X technology? Patient with ischemic cardiomyopathy, patient with non-ischemic cardiomyopathy, and first line for any patient requiring an ICD who does not require atrial pacing. I always say myself, if I don't need atrial pacing, why to put two lead? And if I put one lead, why not to have atrial sense? It's just an additional information that costs me nothing, but is clinically extremely relevant. So we also know there is a significantly lower incidence of inappropriate ICD therapies with DX when compared to single chamber ICD. This study show it very well that single chamber is worse than BDD for inappropriate shocks. How the sensing work? Well, the DX operates as a system. The atrial signal amplification for 4 times, and there's a converter for a fast signal processing, and there is a high and low pass filter. It's an 8.4 French single coil lead with 2 floating atrial electrodes, an optimized depot spacing, a large atrial sensing, and is made of silicone with an additional polyurethane cover. A lot of studies have been done, all supported by BIOTRONIK, I have to say, with an expansive body of clinical evidence supporting this type of technology. And as already said, is another slide just to show you that the signal get amplified and converted. So even in patients that have an atrial scar, we can still, with the sensing dipole, obtain a reasonable signal that could be very usable for the reason that we have been listening tonight. I want to repeat it again: SVT discrimination versus VT, inappropriate shocks, and detection of subclinical and clinical atrial fibrillation or atrial tachyarrhythmia. This study by Dr. Mitacchione is an Italian study. Look at the new onset device detected AFib. Again, in patient with ADX is again a very nice study, and it's a multi-center study with about 5 years follow-up. I showed this at the beginning, but it's about 1,300 patients, 527 with a DX and 822 with a dual chamber ICD, and you can see the freedom from DDAF at more than 24-hour match cohort. And so after propensity score matching, devices that is subclinical AFib rates were similar in the XICD when compared to DDD. So your single chamber ICD will behave as a dual chamber ICD with 98.7% of patients who did not require atrial lead upgrade. We already saw this before, but I wanted to reinforce the concept and show this you again. We already saw this information before, but again, there is a very rare need for upgrade to an atrial lead. And this has been also shown in this study by Dr. Biffy, which we already saw before. And I don't think I want to go through again to this registry, the THINK registry that we already discussed a little bit before, but that we can summarize saying that the new onset of AFib, AT, BDX can allow you, it's really comparable to dual chamber and superior to a single chamber as a concept. And this is extremely important. Now, what about biventricular pacing or physiologic pacing? Do we need an atrial lead or not? And that's another form of debate. I don't think we need the atrial lead all the time. Most of the time, we put the atrial lead not for pacing need, but for AV sequence detection, for having a good and more comfortable physiologic synchrony between the atrium and the ventricle. In this study here, the scope of the study was what fraction of CRTD patients don't require atrial pacing in about 5,000 patients with the CRTD system, 4,500 with a traditional CRTD, and 387 with the DX. Definition of need for atrial pain defined as an atrial pacing less than 4% and maxi daily pacing that do not exceed the 9%. And you can see here about 20% of patients did not need atrial pacing, and within the patient that had a CRT-DX, about 2% required the AHRE lead upgrade. Again, different study, same or similar outcomes. In the BIO-reduced study here, the biventricular cardiac resynchronization therapy with atrial sensitive but not atrial lead, and the author performed a prospective registry of patient complication and response to the therapy. So what was found in this BIO-reduced study, out of 110 patients at a 12 months follow-up in 21 sites, again, upgrade rate was only 1.8%, and there was the need for atrial pacing. So this study, also by Dr. Shaikh, showed that the novel two-lead cardiac resynchronization therapy system provides a CRT responses with less complication than a conventional three-lead system, and these were the results of the QPXL lead registry. And Shaikh et al. Found that the CRT-DX performed the same as a three-lead CRT system, but significantly fewer complications and fewer inappropriate shock. And I think these are very relevant information. And this is a comparison of CRT-DX that has a fewer complication and fewer shocks between a three-lead biventricular pacing system. No minimal difference is observed in response to the CRTD between two leads and three leads. That's also very important, and no meaningful difference in LV pacing percentage or patient activity. So I don't want to, bother you more. I think you all are gonna have dinner. I'm available for any of the question. I think and I hope that I supported, because I don't want to convince you, but I supported my opinion with data that come from study conducted by Biotronic, but also from study that are there in the literature, that detection of supraventricular arrhythmias and subclinical AFib or AFib is very important to manage patient at a stroke risk, discrimination of arrhythmias for diagnosis and for reducing the inappropriate shock. It's very, very important that adding a second or a third lead, it's increased the risk of complication in the patient we treat, and needs to be done only when extremely necessary. And that every tool that technology can give us is welcome, and I'm happy to use. Thank you very much for your attention.